neurodegenerative disorder. It's a disorder where the nerves are dying for some reason. We don't know necessarily why or trying to understand. Alzheimer's disease is one, ALS is one, and Parkinson's one. In Parkinson's, we see a loss of dopamine in the basal ganglia. We also see the sympathetic nervous system has a loss of norepinephrine. And if we look under a microscope, we see these Lewy bodies, which is a clump of alpha-synuclein. And that's what we see in pathology. And when we look at Parkinson's disease, we have different types of symptoms. We have the motor symptoms, which most people are very familiar with the motor symptoms. That's the tremor, the stiffness, the slow movement, the balance difficulty, and the shuffle gait. But there are also a lot of non-motor symptoms that are part of Parkinson's disease, such as depression, anxiety, memory loss, fatigue, constipation, lightheadedness, blood pressure issues, loss of smell, and sleep difficulties. When we look at sleep difficulties in patients with Parkinson's disease, they're very common. It is the most common non-motor symptom of Parkinson's disease. 98% of people with Parkinson's disease will have some sleep disturbance. So pretty much almost everybody. Common symptom that we see in Parkinson's disease is insomnia. Insomnia is those who give themselves the right opportunity to sleep, but just aren't sleeping. So they lay down, they're giving them a good environment to sleep, but they're just not sleeping. That's different than sleep deprivation, whereas someone who is just keeping themselves up, watching TV, doing this, that, and not actually laying down to sleep. Then there are people who are sleepy during the daytime. So hypersomnia, those are people who doze off at times they don't want to, falling asleep during the daytime, and they're sleeping at night. Restless legs is common in people with Parkinson's. So that is the feeling of uncomfortable feeling in your legs, like you need to move them around. And then circadian rhythm disorder. So your circadian rhythm we'll talk about more, but that's your internal clock. And there are disorders associated with that. And then obstructive sleep apnea. Obstructive sleep apnea is when there's airway in your back of your throat. And when you fall asleep, the muscles in your body fall asleep. They fall asleep in your throat as well. And when you breathe in, you create a suction, and that suction's strong enough, it collapses the airway. So you breathe in, you collapse the airway. Obviously, your body doesn't like that, and it will wake you up to breathe. And that can cause you to have fragmented sleep at night and then be sleepy during the daytime. Sleep apnea is common against all men, but after menopause, women catch up with men. And obviously, if you have any disorder with your nervous system and muscle and control, that increases your risk. So Parkinson's patients do have a higher risk of sleep apnea. And then there's REM behavior disorder. This is when you're in REM sleep, dream sleep, and people are acting out their dreams. So their eyes are closed, they're acting out, punching, kicking, that they could be dreaming that something's, they're fighting a dog or whatever, and they're doing that in their sleep. So when we look at sleep disorders, we always have this difficulty of what came first, the chicken or the egg. So with Parkinson's disease, we run in the same problem. What are these sleep disturbances are related to the sleep disorder themselves, and what are the medication side effects? Because a lot of patients who come to me for sleep problem and Parkinson's are usually on a lot of medication. And medication, no matter how well we try, every medication is going to have side effects. So we're left is the problem the side effect of the medication that's treating this, or is it the disease itself? And we struggled to figure this out. When we look at sleep studies, most people who Parkinson's have had sleep studies, almost all of them are on medication when they go for the sleep studies. So it's very hard to study this, what came first, because really you need someone with Parkinson's disease that's never been on any medication. And that doesn't happen too often in an academic center to catch those people before they've been put on any medication. But what we find when we do sleep studies is we see the total amount of sleep they get in the night is a lower. They have decreased slow wave sleep, which is the deep sleep is slow wave. And then they have decreased REM sleep, which is the dream sleep. Now, some of that could be artifact because we know people with Parkinson's are higher risk for REM behavior disorder. And your brain waves look the same when you're asleep and when you're awake. So how do we score REM sleep is we see the brain waves look similar to awake, but we see no movement and there are no increased tone. Well, if you have a disorder where you have increased tone and you're able to move, it can be very hard you may miss REM sleep because you may score it as awake because it may look awake. The only way to really know, you need a trained tech that's looking at the patient, can tell their eyes are closed and they're clearly asleep, but often it's missed. And we also see with sleep studies, we see increased wakefulness after sleep, meaning they fall asleep and they're more times awake. The REM latency, how quickly once they fall asleep do they go into REM sleep, is delayed. We see a higher apnea-hypopnea index. What is that? So that's measuring sleep apnea. So apnea means stop breathing. Hypopnea means decreased breathing. So this is looking at how many times you stop or decrease breathing per hour. And that is higher. And that just is what we talked about before, that sleep apnea is higher in patients with Parkinson's. And periodic leg movement. Periodic leg movements is when you have flexion at your knee, hip, and ankle. So you do this kind of movement. Sorry, people virtual. I'm not tall enough to show you what I'm doing, but it's just flexion at the hip, knee, and ankle. And they do this in the sleep periodically like this, about every maybe 20 seconds or so, be like, do this. That's what PLMs are. So there are some things that are controversial. And one is looking at obstructive sleep apnea. In Parkinson's, we clearly see a higher HI in men compared to healthy controls. We don't see that relationship as strongly with women. And so some people are, is it just men that we see the increased risk of OSA and Parkinson's? But we don't know. When we look at restless legs is very hard to diagnose because the patient has to describe it to them. And not every person describes the same feeling the same way. So I have many patients that will come to me and they'll say, my leg is numb. To me, numb means you can't feel it. Like if I touch you, I don't feel it, or pins and needle. But some people are like, no, I can feel it. It feels fine. It's just heavy. I can't move it. And I'm like, well, that's weakness. So a person may use the word numb to describe weakness, but in my head, numb means lack of feeling. And so sometimes it can take a while to figure out what actually are you experiencing. And we also know that Parkinson's disease has other things that can mimic restless legs. You can have what we call akathisias, like this inside restlessness that isn't restless legs, but you just feel like you need to move. You have dyskinesias that you're moving, leg cramps, and then you can get dystonia where you just have to move. And then there's times that you are just stiff and you want to move, but you can't move. That's not really restless legs, just part of the Parkinson's.
AHI is?
Apnea-hypopnea index. Yep. So that's what we talked about here, the apnea-hypopnea index. Yep. So it means more sleep apnea. And so because if we were to give out a questionnaire about what your symptoms are next, because a lot of these studies are questionnaires, a lot of people will mark yes to all these for restless legs, but it's not actually restless legs they're having. They could be having a cramp or dystonia or something else. And if you take the people and you actually have a sleep physician ask them the question and really dig into it, we can find that they're actually very different. So when you look at the studies that a sleep doctor is actually talking to the patient and figuring out, do they have restless legs? The diagnosis of restless legs isn't that high. But if we send out questionnaires, the diagnosis is much higher. In big studies, we can't do that with the doctor talking to every person. It's usually sent by questionnaires. I will add, I am on call today. That's not me, but I am on call today. So I do have my phone on for that, but hopefully I won't get called during this. I apologize. Not that I expect you to know this, but I think this helps you understand a little bit about sleep and what problems can have. So here is a picture of our brain. Here's the cortex of the brain, the cerebellum back of the brain. And then here's the brain stem. And Parkinson's affects this kind of area of the brain. Okay. And this is the pathway that keeps us awake. So there's two pathways that keeps us awake. This kind of yellowish that goes to the thalamus, and it relies on acetylcholine to activate the thalamus, and then it goes through the cortex. Then there's another pathway that uses norepinephrine, it uses serotonin, it uses dopamine, acetylcholine, a little bit histamine, and orexin. This is the pathway, a second pathway that keeps us awake. So these things, all these chemicals are used to help keep us awake. Now you may have heard some of these things, maybe like in medications, like dopamine and some histamine, acetylcholine, and serotonin and norepinephrine. Some of those may sound familiar because a lot of the medications we use affect those receptors, or I should say neurotransmitters. When we look at sleep, what causes us to sleep, it's basically there's a nucleus, the VLPO, that basically suppresses all those things I just talked about. Okay, so it uses the same type of neurotransmitters. These neurotransmitters work in a very closely, beautiful, delicate balance for everything to go well. You knock one off, things get out of whack and problems start to happen. And so your sleep is very delicate to keep everything kind of working well. When we look at the medications, we have a lot of people are on dopamine agonists because we know Parkinson's, you have a lack of dopamine. So we want to give you some dopamine. Dopamine agonists can have side effects that affect sleep because it's affecting the same area and neurotransmitters that play a role in keeping us awake and keeping us asleep. So some people will have sleep attacks where they feel fine all of a sudden they're asleep, like narcolepsy. They can have daytime sleepiness. They can have insomnia. And they can have hallucinations with the dopamine agonists. Then there's antidepressant medications. There's a selective serotonin reuptake inhibitors. So serotonin, which is one of the neurotransmitters we talked about. There's also serotonin norepinephrine. Again, we talked about norepinephrine. So these antidepressant medications work really well for depression and anxiety, but unfortunately they can come with side effects. And some people will have insomnia, some people will have hypersomnia, some people will have REM behavior disorder or RBD, some will have periodic leg movements of sleep, the PLMS, and then restless legs. Then there's acetylcholinesterase inhibitors. These are the medications we often use for people that have memory problems with their Parkinson's, like Aricept, and there's other ones. Those can be associated with it. Some people get insomnia and some people get hypersomnia. So you can see the drugs we use, why they can cause sleep problems, because they're affecting the neurotransmitters that play a major role in our sleep. But also Parkinson's, as I mentioned over here, I go back just a little bit, the Parkinson's disease itself causes problems in this part of the brain too. So Parkinson's disease by itself will cause problems with daytime sleepiness, trouble with sleeping at night, the REM behavior disorder and all this. So it's really hard to know which is the medication and which is the disease itself, because the disease can cause all this too. So the motor symptoms can also play a role in our trouble sleeping. Because if you have a really bad tremor, that may interfere with your ability to fall asleep. Or if you wake up in the middle of the night, you may have that tremor and that may bother you, or it may bother your bed partner. Also, if you have a lot of trouble rolling over bed, that can make it difficulty. Everyone about every 2 hours should wake up and reposition themselves and get themselves comfortable. Everybody should do that. If you don't do it, you're going to end up with bed sores. Most of us have very little memory of waking up and rolling over. We kind of do this. We're kind of half asleep. We just roll over, go back to sleep. But if you have a hard time rolling over because of the Parkinson's, you just can't roll over nonchalantly, just done. It takes a lot of effort to roll over. So because of that, you have to be more conscious. That conscious part of the brain has to be more activated so you can roll over and get repositioned. And so you're going to be more aware of these awakenings. This is normal awakenings. This will not interfere with your ability to function during the daytime. It may be bothersome to you, but this is actually pretty normal. It's only a problem if you have trouble falling back to sleep. So if you wake up and you reposition yourself and then it's like an hour and you can't fall back to sleep, that's a problem. But if you wake up and you roll over, reposition yourself and you fall back to sleep in in 5 minutes, 10 minutes, that's actually pretty normal. And that's because our body needs to reposition basically every 90 to 2 hours, because we naturally go through a cycle of sleep that's about every 90 minutes to 2 hours. And then you wake up and we reposition ourselves. I do get a lot of episodes where someone may have severe Parkinson's and their caregiver has to help them move over because they can't do it on their own. And they want them to sleep all night long. And I'm like, well, we can give drugs to help you sleep all night long, but unfortunately, somebody has to go in every 2 hours and reposition them. So because the patient really needs to be repositioned every 2 hours, otherwise you're going to get a bed sore, and that leads down a whole mess of problems that you don't want to have to deal with. Circadian rhythm is also very important to our sleep, and probably more important to Parkinson's disease than we previously realized. So circadian rhythm, that's our internal clock. So we have internal clocks that tell us when to wake up and be asleep. So if we were to look at how sleepy we are, around 5 to 8 a.m., most of us are the sleepiest. And then we're the most awake, usually around noon. And then there's another dip in the afternoon, 2 to 4. Has nothing to do with lunch. That's why we get sleepy after lunch. And then we get sleepy again later. So if you were to take a person and you want them to fall asleep here, you can see it's very hard for them to fall asleep because our internal clock wants us to be awake. But if you want to try to fall asleep here, actually it's a lot easier. So this is our internal clock. We're born with internal clocks, but there are things that play a major role in strengthening our internal clock, which I'll talk about a little bit later. But besides our brain have an internal clock, every organ in our body has an internal clock. So our liver cells have internal clock, little clocks that release different things at certain times. Our pancreas, our thyroid, everything. Our whole body has all these little internal clocks, and they do certain things at certain times. And our bodies were designed for all these to line up at the right time. So like at night when we sleep. So when you're asleep, we produce growth hormone. Your body produces that during slow wave. Well, your body wants that growth hormone being produced during certain times of night. So if you sleep here and you have your slow wave sleep, you're going to produce growth hormone now. But your body wants to produce here to have the maximum health. So if you're sleeping at times that are not lined up with your circadian rhythm, it's going to get all out of whack. And we know, like, diabetes is a good example. Patients that sleep at random times and don't have a regular time going to bed, waking up, that their diabetes is harder to control. That's because hormones have these clocks. So all these little things have to be lined up a certain way. You kind of think about the game as when I'm a kid, where you had the beans on here, and everyone kept putting a bean on this little plate, and you don't want it to tip over the beans. That's kind of like how our body is. Everything is very perfectly dedicated. You knock one piece off, it may not tip everything, but you knock off a few, and then things are just kind of falling apart. So it's very important. And so when we look at Parkinson's disease and our circadian, we find a few things. So if we look at people who are healthy, here we're going to look at sleep cycle, sleep architecture, and clock. That's their internal clock. So we have healthy people. They have normal sleep schedule, normal sleep architecture with REM and non-REM, and normal circadian rhythm. If we look at healthy people, specifically with women, those who have less light exposure during the daytime have a higher incidence of Parkinson's. We also know that those with Parkinson's have often many of them have low vitamin D. How do we get vitamin D? Sun. So there seems to be a relationship, sun, vitamin D, and Parkinson's. There's definitely a little bit relationship to that. When we look at, we've learned a lot through patients with RBD, REM behavior disorder, that do not have Parkinson's. So we see a lot of people who get acting out their dreams at night and sleep, but otherwise they're healthy, no symptom. And so we now know those people end up turning into having Parkinson's. That's a very beginning symptom of Parkinson's. And it may be 10 years before they develop any motor symptom. So we're learning a lot through this group. Early on, their wake cycle is normal. They are acting out their dreams at night. Their non-REM sleep is fine. We don't know yet about their circadian rhythm. We're trying to study that to see, do they have an abnormality with their circadian rhythm? And they may have a little bit, and I'll talk about that later. And so when I have a patient like that with trouble sleeping, it's very hard to figure out. You can't just be, I have trouble sleeping. Okay, let's just give you a med, whatever. It's difficult to sort out what is actually causing the trouble sleeping. Is it the movements, meaning the tremor or the rolling over the bed? Is it that they're sleeping all during the daytime? So if you sleep during the daytime, you're not going to sleep at night. Or is it the medications? Or is it the Parkinson's disease itself? So it requires a lot of history. I'm going to ask a lot of questions. We have to figure out what is going on. A lot of questions. Then maybe sometimes a test, like a sleep study. And then lastly, it's stepwise, because often one person may have multiple things to cause their sleep. And so we have to treat one at a time. So more than one problem is very common. A lot of times patients with Parkinson's have many things going on. So we have to do a stepwise approach. So the first thing we always in medicine like to do is let's see what we can fix without medication. You guys are on enough medication as it is. So we don't want to add more medication. So we're going to try to improve things as best as we can without medication. And the things that we know is improving your sleep hygiene is very important to everyone. No matter what problem you have, having good sleep hygiene is very important. If you have a sleep disorder, it's even extremely important to follow that. I hear a lot of people say, well, I got Parkinson's, so I don't need to worry about being healthy otherwise. I don't need to go outside. I don't need to exercise. I got this disease. I don't need to do that. It's even more important for you to do it. Or I have patients with like narcolepsy. They're like, well, I have this disorder where I fall asleep. So who cares about having good sleep hygiene, getting exercise, that? I'm like, no, it's even more important for people with sleep disorders to follow this than, because you have no reserve. If you have no reserve, you can't slack on anything. You got to do everything healthy as you can. And then lastly, we'd like to adjust the current medications you're on. So if you're on medications that are causing problems, we try to avoid things if they're not helping, or lower if we don't need to. And it could be hard. And sometimes an individual person has to decide what's more important. I'm like, this medication gives me this benefit, but causes me this kind of problem, which is worse, or this amount of benefit and this kind of problem. Okay, I'll deal with that. Or is it like this? I get very little benefit, but a lot of problem. Okay, maybe I don't want that benefit. No one can answer that except for the person, because no one experienced that. A doctor doesn't know what is worse for you. Well, they could tell you what if there's worse, not symptoms you feel, but like liver damage, things like that, we can tell you if it's a dangerous drug. But otherwise, some of the medications we use for Parkinson's purely to help the symptoms. And so you have to tell us, is it helping the symptoms enough to deal with the side effects? So when we look at normal sleep, what can we do to help our normal sleep? In here, you can see our circadian rhythm. This is the cycling that goes up and down. And I don't know, you don't see my mouse up there, do you? I don't know how to get it. Can I get it up there? Up there? No.
It shows up.
Oh, wait, there it is.
bar. There you go.
There we go. Okay, this is taking some eye-hand coordination, huh? So here is my circadian rhythm, or cycle. So we go to sleep and awake, asleep and awake. All right. And so you could think of the circadian rhythm as someone swinging. So they go up and back, up and back. But to keep going up and back, there's things you need. You got to push at the right point, and you got to pull at the right point. You got to pump those legs. And if you stop pumping, or no one's pushing you, what happens? It just slowly, slowly, slowly stops. Or if you try pushing at the wrong time or pumping at the wrong time, then you just kind of don't do anything either. Sleep is exactly the same way with our internal clock. So we have something that is the push, that pushes our sleep away, that tells us it's time to be awake. We don't want sleep near us, time to be awake. Does anybody know what that push is?
Light.
Yes, it's light. So bright light pushes our sleep away. Bright light lowers our melatonin levels and lets our body know it's time to be awake. This amount of light, not enough. You have to be outside. You could be in the shade, but you need to be inside. To give you an idea. So out natural light is so important. Being by a window, glass is very good. It has all these UV protection, all this kind of stuff to help. So being out by a window isn't going to help. You need to be outside. You can be sitting, you can be in the shade, you don't have to be in direct sunlight, but being outside is so important. And then, anybody know what the pull is? What pulls our sleep towards it? Yes, darkness. So when it gets dark out, about 2 hours later, our melatonin peaks. So like the sun goes down, it gets dark, our body starts producing melatonin, and then it produces it about 2 hours after it gets dark, and then our body starts getting sleepy. Melatonin doesn't put us necessarily to sleep. It tells our body when to sleep. So if you're in darkness all during the day, your body's thinking it's time to sleep all day. So that's why you need light. And if you're in the computer on your phone, have the TV going, that's telling us, oh, it's time to be awake. So we need it dark at night. Now we live in the same, for those of us that are in Indianapolis, I know there could be people logging in from elsewhere. Indianapolis is in the wrong time zone. We should be at least central. At least central for the winter months. In the summer months, we should actually be probably Pacific. So solar noon, does anybody know when solar noon is in Indianapolis right now in the summer? when the sun is the highest. But I mean, what time of the day? 2 o'clock. At 2 o'clock, our sun is the highest. So we're 2 hours off of the solar noon. Our bodies were meant for noon to be when the sun is the highest. So we're 2 hours off for a time zone where we should be. And so that we do know that creates problem. We see higher incidence of cancer. We see test scores on kids are worse. I mean, there's all kind of problems that we see, higher death rate, all kinds of stuff. So we know that this light during certain times of the day, tied with our circadian rhythm and our social behavior, really need to map out all at the same time. And so unfortunately, because it's so light here late, that can screw up our sleep and make it hard for a lot of people to sleep because it's getting darker earlier now. I think it's around like 8 o'clock-ish. It's getting dark now. So that's not great, but it's at least better than it was like 9:30 at the beginning of the summer. I mean, in June. And so keeping that darkness at night, bright light in the morning is very important to train our circadian rhythm. So the one thing everybody should be doing, especially people with Parkinson's, is definitely making sure when it's dark outside, dark in the house, or at least, darkish, like keep it dark at least 2 hours before bedtime, 3 hours before bedtime. And then when it's light outside, make sure it's laid out in the room. Don't keep everything dark in the house, and make sure you get outside. Outside during the day, especially before noon, is very important to help your circadian rhythm. Other things, and so here's another drawing of our circadian rhythm. See, so here's our internal clock telling us to be awake, okay? And so our internal clock works the hardest to keep us awake right before we go to bed. And that's why a lot of people get that second wind. Okay. The other thing that turns us when to sleep is how long it's been since we've been up. So if you've been up for an hour, you don't have a very strong drive to sleep. But if you've been up for 24 hours, you have a very strong to sleep. So our internal clock and our sleep drive, our homeostatic drive, wants to line up at the same time. So that's why we fall asleep right here when our internal clock shuts off around 10 o'clock and our drive to sleep is very high. That's the ideal time to sleep. But let's say you decide to take a nap during the day. Well, now our homeostatic drive is not there. So now we're not going to sleep at night. Now, this may not happen night to night, but we will see this over time. And this is very common in people who retire, who are ill. What happens is you finally retire and be like, well, I didn't sleep very well last night, so I can sleep in today, or I'm going to take a nap. And then they don't sleep very well the next night. And so they're like, well, I don't have anything to do. I could just sleep in. So then they sleep in or they take a nap, and then it just keeps going and going and going and get worse. Other thing that we see is a lot of people think, well, they're ill. They need their rest. They need to sleep. And that's fine. If you sleep well at night, you can take a nap during the daytime. But if you don't sleep well at night, taking a nap during the daytime will make it harder to sleep at night. It's okay to physically rest, be like, okay, I'm going to sit down in this recliner and rest your muscles and things like that. But if you're having trouble sleeping at night, you want to try to avoid falling asleep. Now, it can be hard because of the medications and all that, but those are things you can do behavioral wise to help you sleep better at night. Now, once we do the things that we can, okay, I got a person, they're getting outside. They're getting outside. They are exercising. They are using the bedroom, just going to bed at a regular time, waking up at the regular time, avoiding naps. They've done all those things and they're still having problems. We got to look, okay, we've done that. Now what's next? So one thing we could be like, okay, maybe they have sleep apnea. Are they snoring? Are they gasping for air? Not everyone with Parkinson's snores though and can still have sleep apnea. So then I'd be like, okay, I think they may have sleep apnea. I'm going to do a sleep study. Generally, a sleep study is usually used to see if they have sleep apnea. I will sometimes, hold on. Sorry, I think that is my son trying to figure out how to get more time on the computer. And yes, I know. I was like, he's going to keep calling me, but he's not going to get it. All right.
Take it away.
I know. I control everything, on our house through the phone now, so he can't do anything.
And you love it.
Yes. So we'll do the sleep study to really look for sleep apnea. I usually don't have to do it in someone that has Parkinson's it sounds classical, like REM behavior disorder, unless there's something that sounds like atypical. I'm not sure what that is. Sometimes I will to see what's really going on. It's more often in people who I think, do they have REM behavior disorder? I'm not really sure. Then I may do a sleep study to kind of see what's going on. And then other thing, pharmacological treatment. We treat people with trouble sleeping with Parkinson's disease no different than anybody else, really. Like the medications are the same. However, there's more side effects. So benzodiazepines worsen our respiratory drive, and they worsen our thinking. So our memory gets worse. Well, patients with Parkinson's already have some respiratory issues, and they already have trouble with memory, so we don't want to make that worse. And then there's wake promoting medications. So someone who's falling asleep during the daytime because the medications just make them fall asleep all the time. There are medications that help keep you awake, like modafinil and other stimulants like methylphenidate or Ritalin, things like that. The problem is they do have increased risk of cardiovascular disease, so stroke and heart attack. And most people, Parkinson's, are older, and so most old people have problems for stroke and heart attacks. So we have to balance that. Do I use sometimes these drugs, even though there is increased risk? Sometimes I do, because quality of life may be more important than the risk of heart disease and stroke. We also don't have any evidence that artificially inducing sleep is actually good for your health. So the only reason to do it is actually if you feel better during the daytime. Do you have more energy? Because a lot of sleep aids will cause you to actually sometimes be more groggy during the daytime. They increase your risk for falls, which you're already at risk for falls. And they can make your memory worse. Like benzodiazepine have been shown to associate with increased risk for Alzheimer's. And we know they also increase your risk for cancer. So definitely medications that help you sleep are not good for your health overall. Like if anything, they may make your health worse, but sometimes we do it if your quality of life is better, because we're not necessarily worrying about how long you live with Parkinson's. It's more about quality of life now. So sometimes we will prescribe these medications, but we also have to be very careful because of the fall risk and things like that. So obviously we like to work on circadian rhythm and light and exercise and things like that is probably more important and better for your health than the medications, but we do use medications purely for quality of life, but they do come with problems. Now, REM behavior disorder. So this is the acting out your dreams in your sleep. Eyes are closed. They can cause injury to the person or the bed partner. And said, eyes are closed. This is an example. So when I read sleep studies, this is what I'm looking at. Let me get my mouse up here again. So here is my EEG. This is how I tell if they're awake, asleep. I can actually maybe wake, asleep, all that kind of stuff. This person's in REM sleep. Normally during REM sleep, this is their muscle. This is electrodes that we have on their chin, arm, and leg. And normally we should see no activity. It should be pretty flat, because when you're in REM sleep, you're paralyzed. You can't move anything except for your eyes and your breathing. But in this person, they have increased tone. So now they're able to move around in the REM sleep. And then this down here is all just the breathing stuff. So here's an example of too much tone. Interestingly, if we were to capture video of a person with Parkinson's having a REM behavior disorder episode, the movements are actually pretty normal. So you can have someone with severe Parkinson's that can barely move. They're pretty stiff, barely move, but in their dream, they're like moving just fine and acting. It's pretty interesting how that is. And it's just that the part of the brain that's doing these movements is actually not the part of the brain up here, the thinking part. It's more the brainstem that's causing these movements. Let's see, how do I get to the next slide? Okay. So REM behavior disorder, we have a lot of people say, well, they jump and they kick and punch. And so a lot of things can do different movements like that. So we have to talk and kind of figure things out. One, we have what we call pseudo REM behavior disorder, meaning people with obstructive sleep apnea can have a lot of jerking movement at night. So if you can't breathe, you can quickly jerk your arms up or kick your leg out. So I have a lot of people to say, a caregiver or a spouse will say they punch or kick in their sleep. And then we just see they just have bad sleep apnea. And we treat that and the movements go away. So that's what we call pseudo REM behavior disorder. So it's like REM behavior disorder is different. Antidepressants can make REM behavior disorder worse, and they can also just cause REM behavior disorder. So sometimes if the antidepressant really isn't working or not working that much, or you didn't really notice, well, I was on this dose up there, I don't really notice a difference. See if we can go down and see if we lower the dose of the behaviors get better. Safety is the most important thing. So getting rid of any sharp objects, sometimes having the mattress lower. So if you fall off, you're not going to break a hip. Padding, things like that is probably the biggest thing. There are medications that we use to treat REM behavior disorder. Clonazepam, which is a benzodiazepine. Again, it does increase your fall risk, but with REM behavior disorder, you're going to fall out of bed anyway. So we'd rather treat it and prevent you from falling out of bed than worry about the side effects. And then melatonin. Interestingly, when you give melatonin, melatonin is the part that tells our body when sleep should happen. So if you just take melatonin at any time, someone with REM behavior disorder, and they sleep, sometimes they go to bed at 8, sometimes midnight, sometimes 2, and they just take it right before bed, and we follow them, the melatonin doesn't usually work that well for REM behavior disorder. But if we have them take it at 10 o'clock every night, just take it at 10 o'clock every night, after about 2 weeks to 3 weeks, then we start seeing the behaviors improve.
The cap, the bottle always says take it 20 minutes before sleep.
I know. Well, that's because the bottle is over the counter, is people selling it to make money and not selling it for REM behavior disorder. So melatonin and our circadian rhythm, if we just look at our circadian rhythm, and we all got up right now and went to Hawaii, we'd all have trouble staying asleep in the morning. We'd be waking up at 3 o'clock in the morning, ready to go. And probably most of us would be ready for bed at 6 p.m., ready to, It takes about 2 weeks to 3 weeks for a body to get totally adjusted from that time change. So it's interesting. We start melatonin for REM behavior disorder at 10 o'clock every night. And the REM behavior disorder doesn't start to improve until 2 to 3 weeks later, which is very similar to our circadian rhythm. And so why the melatonin work probably has nothing to do with the melatonin, like us putting you to sleep. It's probably melatonin is helping to strengthen your circadian rhythm, that your circadian rhythm is probably not strong, and that may be contributing to the REM behavior disorder rather than actually a drug to help the REM disorder directly. And we see this with other things as well. And very interestingly, there's been some studies that in some people, when you stop, like they're on melatonin for a while for REM behavior disorder, and after like 3 months, they stop it, the REM behavior disorder may do well. It doesn't get worse. And it may be because they got their circadian rhythm in sync, and then they're doing other behaviors like getting outside and doing healthy behaviors to keep their circadian rhythm in sync, keeping that wave going up and down, and that's helping their sleep, that circadian rhythm, and not so much the medication. And that medication was just a jump start to get their circadian rhythm going. That's still kind of theory, and we have some other things kind of looking at and supporting that, but it does look like that circadian rhythm probably does play a major role. Other reason, there's been a lot of talk about your gut and Parkinson's. And maybe that bacteria in your gut is a certain thing. Well, they've had mice with Parkinson's disease, and so they started looking at the gut and Parkinson's and different things, and there definitely is some bacteria in our gut that are very sensitive to the circadian rhythm. So your own circadian rhythm affects the gut, your bacteria in your gut. And we know some of those bacteria produce things that are good for you, that may help be protective. And at the same time, if that bacteria is not thriving because your circadian rhythm's all out of whack, there are bacteria that don't care about the circadian rhythm, and they produce things that may be bad for you. We don't know which is it. Is it that the lack of the bacteria that should be naturally thriving with a good circadian rhythm is not producing good things, or is it that then the bad bacteria can take over and produce bad things? We don't know, but we definitely see a change that's happened in people when their circadian rhythm's out of whack. And if you take mice with Parkinson's disease, we see that if you screw up their circadian rhythm, the bacteria in their gut get all out of whack, and then their Parkinson's symptoms start earlier. And genetically determined Parkinson's mice. So definitely our gut plays a role in these symptoms, but your gut bacteria also plays a role in your circadian rhythm. And there's some bacteria in your gut that thrive with exercise. So it's coming out to be like all this studying we learned, we've done all this study over time. What are we learning? What's good for you? Light during the daytime, exercise and sleeping well and eating healthy. It's probably what it's all going to come down to, which we probably already knew what we should. We like to have easy meds that fix that, fix that, fix that. But we're learning that our gut plays a major role with what we eat, with what we exercise, what light exposure we have, and how we sleep. All plays a major role in having a healthy environment for our nervous system. We also, so as I mentioned before, REM behavior disorder, we're going to learn a lot from this and probably find more likely to find treatments that can really, really make a difference. Is that REM behavior disorder, patients with that without Parkinson's, in average they'll develop Parkinson's in 11 years. By 14 years, 90% will have developed a neurodegenerative disorder. So we're really studying that population of people to really figure out what's happening and how can we stop. As you may know, we've tried a lot of drugs to stop Parkinson's from progressing, and they haven't really, in mice, they look good, but when we go to people, and they don't really pan them out. It may be we have to give it to people before they develop the motor symptoms. So we got to give it to people when they have the REM behavior disorder early on. That may be what would help. We don't know yet, but we're definitely studying that. And we also are learning that there's a lot of things out there with skin biopsy and blood tests to start to help diagnosing Parkinson's disease much earlier than we have previously. So we don't have to wait for people to get like really obvious tremor and gait problems. So take home point, I don't even know how I'm doing it. I'm doing okay on time. So patients with Parkinson's disease have a lot of sleep disturbance. It does take a lot of time to figure out what's going on and figuring out different tests that need to be done. And they frequently also have lots of multiple sleep issues going on. So it's usually not just one thing, it's multiple things. And we can only really address one at a time. And then we have to see what's left and then address the next one and then see what's left. Good sleep hygiene. And when I say that, it's like going to bed at the same time, waking up at the same time, using the bedroom for sleep and sex, not watching TV, playing video games, that kind of stuff at night. That's important, but light exposure during the daytime, especially before noon, and exercise is key to improving your sleep. So most of you are here because you do exercise. The only benefit is that they can make this outside, having the rock steady up, be outside. That would be even better, though it may be a little hot right now. Not want to do it. But if they can have the sun in here while you're exercising, that would be even better for you. But you don't need to do both at the same time. You can go for walks or just sit outside as well. But that's key for everybody, but especially patients with Parkinson's. And then neurodegenerative disorders related to Parkinson's and medications used to treat the symptoms may also lead to sleep disturbances. So it can be very difficult to kind of sort out which is which. And we sometimes have to realize we can't make everything perfect, but we try our best to optimize quality of life. And we need your input to know what's worse, the benefit from the medication versus side effect. And so often this requires the sleep doctor and the neurologist to work together. I'm like, I think this medication may be causing this, or this may be doing this. A good key when a medication may be causing a problem is it usually will start it within a month or two of starting the medication. So if you've been on a medication for a long time and then you start having some trouble like 10 years later or 5 years later, it probably has nothing to do with the medication. Usually happens right away. Or as soon as you change up dose, like I was on this dose for a while and then they upped it. And then I noticed all these problems coming later. That's how we can tell it's medication. Okay. Any questions? Let me get this all back up so I can see. I'm freezing. Oops, sorry. I don't know how to fix that. All right. I don't even see where, I try to get the comments going, but I don't know where they are.
Yeah, it might get a little crazy
All right.
if we open up too much,
Yeah.
but why don't we start with who's in the room?
You said that in Indiana, the high noon is 2:00. Is that, do you feel that daylight savings time is detrimental, even though it's
Absolutely.
economically better?
Absolutely. So the question is about daylight saving time. Is that good or bad? It's absolutely bad. And the studies looking at economy actually it's very controversial. The ones that are lobbying the most and have the most data are ones that are purely funded by the people who make the most money by keeping daylight saving times. So the candy industry, they want it to be light at night for Halloween because they figured that means more kids going out trick or treating, and then that means they'll make more money.
And they're a mess for 2 weeks after.
Yes, so if you look at who's lobbying the most, they have the most to gain from this. But for your health, absolutely daylight saving time should go away. In the countries who've tried daylight saving time, they've all gone back to getting, when they went to one, like all year round daylight savings time, it didn't last. They all went through, mainly because kids were dying by getting hit by cars waiting for school buses. Because that's the main thing that happens. So yes, other questions?
I have a question. I have an issue at night where I wind up being wrapped up in the sheets
Mhm.
and can't move. That's kind of a problem.
Mhm.
I went to Brand X to get a sleep study.
Mhm.
They were recommending some kind of pill to take to not move as much or something like that.
Silk sheets we were.
Yeah.
Well, I
Yeah, falling out of it.
I have this comfort linen or something like that.
Yeah.
But that, and then my follow-up question is, this, over-the-counter stuff, like Tylenol PM and stuff like that. What are your views on that?
Okay. So the first question was about getting all tangled up in your sleep with your sheets. So that can happen for couple reasons. If you just move around a lot in your sleep, or if you have REM behavior disorder. So if you do a sleep study and you see that they have a lot of REM behavior disorder, acting out your dreams at night, then using medication to treat that may help. If you don't have that, and you're just one that's rolling over a lot, silk sheets can be very helpful for that, to help you move around a little bit easier so you don't get tangled up in your sheets. Some people try using sleep aids, but again, that's not necessarily going to help your sleep. It's just going to help you not get frustrated with getting wrapped around in the sheets. So you have to decide what's worse, the side effects or the benefit. Like how bad is getting tied up with the sheets? Some people will say, I just get rid of the sheets and I just use a comforter. Because it's a little harder to get wrapped around the comforter, where sheets are easy. Then the other question was about sleep aids, over-the-counter sleep aids, like Benadryl. Tylenol PM just has Benadryl in it. That's what it is. So we know those medications, those who take medications regularly have a higher incidence of dementia. So we have had a study, actually at IU, they did it, that if you take Benadryl regularly or other things with anticholinergic, that you have a higher incidence of dementia.
If you take the Excedrin PM,
Yes, it has Benadryl in it. Yep, all those PM, they're antihistamines. So it's all antihistamine. That's what the PM is. And so anything with the antihistamine increases your risk for dementia. In people who are older, they can have more side effects: dry mouth, troubles urinating, so urinary difficulty, especially in men, and confusion. And so you have to be careful that those medications can cause. They generally overall don't help that much with sleep, other than we know with sleep is a lot of mind games. So if I give you a pill and I tell you this is going to help you sleep, most people, 50%, it will help them sleep, even though it doesn't do anything. It could be like just a water pill or, like sugar.
I'm thinking 3 different pills to help me sleep. And the first day I take it, it works, and then doesn't do anything.
Yeah, because that's your mind. Your mind thinks it's going to help me sleep. And so it will, because you think it helps sleep. So your mind is very strong. Like if you think I'm not going to sleep tonight, you won't. Because a part of the brain that's active when you're thinking, oh, am I going to sleep or is this going to happen? Is that part in our back of our brain. And here, I'll show that keeps us awake. So if I share this again, let me go through this. And then let's see, how do I share this again? Let's see, I'm going to go to, Actually, yeah, I don't even have to share it. Well, no, you guys need to see it though. I don't know if they can do, well, we'll just share it because I don't know. I won't share the whole thing. Okay, so this is the part of the brain that we talked about that keeps us awake. When you're stressed or you're worrying, I'm not going to sleep tonight because if I don't sleep, I won't do this. Oh, I'm not sleeping. What time it is? I'm not sleeping. The part of the brain that's activated when you think that is this part of the brain. What does this part of the brain do? Keep you awake. So now you're thinking, oh, I'm not going to sleep today. So you activated part of the brain that keeps you awake. So then you are more stressed that you're not sleeping. So then you get more mad. So then you activate it even more. And so that's a vicious cycle. So one thing that can help stop that is cognitive behavior therapy. I didn't talk about it in this because it's a lot. Cognitive behavior therapy is done by a psychologist who's trained to do this for sleep, that retrains your brain to sleep, saying as soon as you start thinking, I'm not going to sleep, we have to stop that. We got to get you not worrying about sleep. Because if you start worrying about sleep, you're not going to sleep. The other thing I wanted to mention about Benadryl or any of the PM medications, melatonin, there has been studies where they took a bunch of over-the-counter melatonin and looked to see how much melatonin's in it, and it's all over the place. And some actually have Benadryl in it. So sometimes a lot of my patients I try, and it depends on cost and whether insurance will do it, I will send a prescription pharmacy grade melatonin so that you actually know you're getting melatonin, because over the counter, you don't know what you're getting because it's not controlled.
It's good to know it's not controlled,
Yes.
even though they say it's natural.
Yeah, even though they say it's natural, well, the FDA does not control anything. Even if it's natural, doesn't mean the government doesn't control anything that they say is natural. I don't know how to get out of here now to see any questions or whatever, but
That's okay if we don't
yeah.
do online questions.
How about the nest and that's same thing?
Lunesta has been shown. So all those drugs, when you look at the studies that look at treating insomnia, they have been shown to increase total sleep time 15 to 20 minutes. And why do they work is they cause amnesia. And if you don't remember the night, you assume you slept well. So if we take, if we take people who have sleep problems or insomnia, and we hook them up to EEG, and we wake them up as soon as they hit stage 2 sleep. So they go through 1 to 2, wake them up. 50% of normal people will say they were awake, even though we know they're asleep. People with insomnia is 75% will say they're awake, even though they're asleep. So they're sleeping, they just think they're awake. Because when you're asleep, you don't really know, it's kind of hard. I mean, we've all probably seen people like, wake up, and like, I was awake. I'm like, it's clear they were asleep. And so the studies looking at sleep aids actually seem to work because they're causing amnesia. They're changing your perception. You perceived you actually slept more. You did sleep probably a little bit more, but probably not as much as you think because you don't remember it. So then there's studies looking at, well, what happens when we give you a drug regularly that causes amnesia? What are we doing to your brain long term? And so that's when they started looking at these drugs, and we're seeing association with people who take sleep aids like Lunesta or Ambien or all those type of things regularly. We do see a higher risk of cancer, death, and possibly Alzheimer's disease and memory loss. Do I prescribe it? Yes, because sometimes quality of life is more important than longevity. So sometimes I do. But it's important for you to know that those medications don't come without side effects. Yes.
Yeah, I'm just curious. There's some different applications for CPAP, mouth guard,
Mm-hmm.
or what is it? Inspire.
Yes.
That's come out.
Yes.
You know, also, I think some came out through urology. Can't remember what it was. Second part of my question would be urination syndrome or whatever it's called.
Yep.
Where I wake up every hour and a half to go to the bathroom.
Mm-hmm. So the first question is treating sleep apnea and the different masks. There are many different masks out there, and what's more important is finding one that's comfortable for you. Even if you think you breathe through your mouth, almost everyone that says they're a mouth breather does fine with a nasal mask.
I'm going like this all
Yep.
night, fight boxing.
So then that's hard if you have the REM behavior disorder and you're getting all tangled up. So that can make it difficult. The companies that make the masks obviously try to make things easier. So they have come up with ones with magnets to help get it on and off, but then magnets are so big that if you get over your pacemaker, it can stop your pacemaker. So then they had to recall it. And so now they have to make smaller ones, but they're trying to come up with easy clicks and things to get on and off easily. The Inspire device, that's a pacemaker that goes under your skin. It has a wire that goes into sense when you're breathing under your intercostal. And then it then has a wire that comes up and stimulates your tongue. So it wraps around your tongue. Once you implant that wire to your tongue, you never can remove it. So it's always there. And the Inspire device does not work as well as CPAP, but it's better than nothing. It doesn't work for everybody. So if you're overweight, it's not going to work. You have to be normal weight or just a little bit overweight. But if you're obese, it's not going to work, because how it works is it stimulates your tongue when you sleep. So when you breathe in, your tongue goes out. So you go. That's how it works. So by sticking your tongue out, you're opening up the airway. So if you have when you gain weight on the outside, you gain it on the inside too. So if it's all weight gain, you can't stick your tongue out far enough to open the airway. You can't do it. So it only works with people of normal weight or just a little overweight, that sticking the tongue out can help open the airway a little bit. And when the studies look at this, their goal of helping someone with sleep apnea is dropping their AHI half. So the AHI is, again, how many times you stop or decrease breathing per hour. So normal is below 5. 5 to 15 is mild. 15 to 30 is moderate. Greater than 30 severe. I have some people 100 times an hour. So let's say you get the Inspire device, you're 100 times an hour. Now you're 50 times an hour. That's still very severe. Yes, it's better, but it's still very severe. So it's not necessarily going to improve it completely. Though sometimes we do it and people have that and their CPAP. So there's a lot of people that get the device put in and they use the CPAP, but not as much pressure. You also have to, in order to make it work, you have to have a study to make sure your airway is collapsing the right way, because it only works if your airway collapses this way. But if it goes the whole way it collapses, it doesn't work. Because by sticking the tongue out, you have to open this way. And so you have to have a special thing. But in some people, it can work really well, but it doesn't come without,
You said that sometimes it doesn't work.
Yeah.
But if you stick that thing in your tongue, you can't get rid of it. So
That's
what
correct.
happens to those people?
you have to leave it there. You don't have to turn it on. You can turn it off. You can remove the paste, you can remove the battery pack.
Mhm.
You can remove that, but you can't remove the wire to the tongue. So you have to stay there. It stays there.
What about that other nose thing that you put in your nose and it cleans your nose out? Does that help?
Like neti pot kind of stuff,
Neti pot.
that you
The
mean?
one that you put in your nose and it's got a tube out here and it flushes out your nose.
Yeah, any lavage, I mean, that will help. That usually isn't gonna help treat sleep apnea, but it'll help with nasal congestion and snottiness and dry nose. It looks like someone has their hand raised, but I'm not sure how to unhook them or if I even do it the right way.
Yeah, and I want to be respectful of folks that are here and also online with time, so we'll.
I do see someone ask about marijuana. So that's an interesting area. So marijuana is kind of like alcohol. So alcohol puts you to sleep, but it really messes up your sleep later on. Studies looking at marijuana that seem to do a little bit, like they seem to help them fall asleep, but then we see some problems later on. I've seen people with very abnormal sleep architecture. Their sleep study looks horrible. We got them to stop using marijuana. Everything would normalize. We also know a lot of our studies on marijuana are difficult to do because not every place marijuana is legal. So it's very legal. I can't get a study where I take a group of people, half of you I get marijuana, half of you I don't, and see what happens. Government's not going to prove that. So a lot of the studies are people who use it regularly. And often people who use marijuana regularly have other poor choices that they may do in their life. So it's hard to really make anything just, is it the marijuana or is it other things they're doing? But we see in chronic marijuana users, especially in their 20s, they have a higher incidence of dementia in the long end. So it seems like marijuana may increase your risk for dementia.
You can get the good stuff.
Huh?
You can get the good stuff.
No, so they didn't get the good stuff. So we don't really know. And it's an area that really needs a lot of good studies. There are some studies out there that are very poor, that are clearly designed to make marijuana look like it works. You need studies done that are very non-biased, that we don't care if it works or not work. Let's see what it does. Unfortunately, the studies that are out there aren't really good. There's not as much. The most benefit seems to be for pain. So that seems to be the most benefit that you can get. But for other things, it really does lack any benefit. Yes.
What about magnesium?
So magnesium, there was a study that recently comes out that magnesium may help. You have to make sure you have good kidneys, because if you have bad kidneys, you can end up with too high magnesium, and that creates problems. So you always have to check with your doctor if you're okay. Magnesium may help with sleep. There are some studies out there for natural that may be something that can help if you take it at the same time at night, bedtime, that may help with sleep. It may help with cramps. So that is something you can try. It can also help with constipation too, which I know is a lot of problem, because milk of magnesia is magnesium, is a laxative. So that's something. But any magnesium, things like that, you always want to check with your primary care, because those are things that if you have kidneys don't work well, you can get too high of magnesium levels and run into problems.
I have a question about naps.
Yes.
Should they be light, like people nap in a chair and it's a light sleep? Or is it recommended more of a deep sleep, lay down in the bed for a certain amount of time? What are your thoughts on?
I think if you're going to nap, you should limit it to 20 minutes. If you don't fall asleep in 20 minutes, you didn't need the nap anyways. If you sleep longer than 20 minutes, what's happening, you're going to want to go through a full cycle of sleep. And our body has this thing called sleep inertia. When you're asleep, it wants to stay asleep. And then it'll get all screwed up, because if you start doing a whole cycle of sleep where you get to deep sleep, it's going to want to just keep going. And then your circadian rhythm's all screwed up, and going to feel, a lot of people may feel lousy if they sleep too much.
So it's better not to take naps at all.
Unless you're one that where you sleep fine at night and you're just really sleepy. There are people who just sleep too much. So for them, it's okay. But usually we try to limit it to 20 minutes, 30 minutes the maximum.
Yeah, because like when I have a rough night where I don't sleep, my wife, when I do fall asleep during the day, she goes, well, you needed it. But I really shouldn't take a nap during the day.
Yeah, you should limit. If you feel you must, keep it to 20 minutes.
You mentioned the thyroid relevance.
Mhm.
I'm taking Synthroid, and I generally take it first time I wake up during the night,
Mhm.
because it keeps away from my food.
Yeah.
It could be any time from 12:30 to 5:30. Does that randomness affect my sleep? And secondly, I've been on trazodone,
Mhm.
50 milligrams for probably 15 years,
Mhm.
and wondering what the issues are as far as getting off of that.
Yep. So for the first, the thyroid, when to take thyroid medication, does it make a difference taking it? We don't have any proof one way or the other. My guess is, knowing our body is so strict with clock, it probably is better to take it the same time every day, but I don't have any proof to support that. That's just in my head and what I see. So I don't really know that really makes, and how much benefit it gets, I don't know if it's enough to make yourself get up at the same time. I don't really know that. And then I already forgot what your second question was.
50 milligrams of trazodone.
Oh, trazodone. So
Side effects and the side effects of stopping.
yeah, so trazodone, a lot of people are put on trazodone for sleep. Trazodone is an old antidepressant medication that has a side effect of making us sleepy. Out of all the sleep aids, that tends to have the highest fall risk. Highest fall risk, falling, like break your, and unfortunately we know when we get older, if you fall and break a hip, most people don't live a year after that. So preventing a broken hip is very important. So coming off of a medication. So if you want to come off a sleep aid, you're on it. The first thing is getting a real strict sleep habit, meaning if I sleep 8 hours a day, well, that's a lot. If you're sleeping 8 hours a day, you don't need the trazodone. Let's say you're sleeping 6 hours a day. Then give yourself 6 hours in bed. Lock in the wake up time, lock in the bedtime. You go to bed at that time and you wake up at that time, no matter what, no sleeping in. And then once you're sleeping well, in that time, get rid of the trazodone, lower off the trazodone. And obviously do this with your doctor's help. And then you're still sleeping good, going 6 to 6. Then if you want to get more sleep, start going to bed 15 minutes earlier. And do that for a couple of weeks. And then if you're sleeping good, okay, then I'm going to go another 15 minutes early and slowly work to the amount of sleep you need. The one thing you shouldn't do, nobody needs to spend 12 hours in bed. Nobody sleeps 12 hours. If you spend 12 hours in bed, your sleep's going to be a mess. Limit the time in bed to what you actually are sleeping. So if you're only sleeping 8 hours a day, only spend 8 hours in bed. If you're sleeping 7 hours a day, just spend 7 hours a day. I see a lot of people say, well, I didn't sleep, so I'm going to go to bed 2 hours early. All that does is screw up your sleep even more, because the more you spend in bed, the more you're telling yourself it's okay to be awake in bed. So there's many people, as soon as they get home and they put a key in the door or pull in the driveway, they immediately have to go to the bathroom. I know I am one of those. I drop my purse and it's like running to the bathroom. There's nothing to do with the key driveway that has anything to do with urination. I've trained myself. I'm home, now I go. I'm home, now I go. You could do the same thing with sleep. How do you do it? Stay awake in bed. So now your brain's gonna think, bed, awake, bed, awake, bed, awake. And then it's gonna be all screwed up. So don't spend a lot of time awake in bed is a very important thing.
How do you retrain yourself to go to the bathroom?
The bathroom, okay, I didn't ask that one. So go in the bathroom a lot at night. Some of it, untreated sleep apnea does cause nocturia. So if you have untreated sleep apnea, you frequently have to urinate more at night. Then there's a lot of people that do that. Prostate problems can, which is common in people, especially as they get older. So talking to your doctor about prostate. Making sure you're not taking any medication that causes you to urinate a lot. Like if you're on heart medication, like Lasix, don't take that at night. That makes you pee. Don't do it at night. Do it in the daytime. Try to avoid drinking water before bedtime, a couple hours before bed, so you don't have to go. Now, the other thing we see, a lot of people wake up. It wasn't that they urinated that made them wake up. They just wake up because, you're trying to get comfortable and it's hard. I got to move over and get things. And then you're awake. I'm like, okay, I think I have to pee. And so if you're going to the bathroom and you're not urinating a lot, it's probably not causing you to wake up. You're waking up and then you feel a little bit and then going. But if you wake up and you are going to the bathroom a lot, then that's the time to decrease the amount you drink at night. Or look, because one thing we know, like if you get swelling in your legs, what helps get rid of the swelling is we need to get your legs above your heart. When do you get your legs above your heart? At night when you sleep. So at night when you're asleep, all that fluid in your legs is going to go up to your heart and get shoved to your kidneys, and you're going to get rid of it. So if you have a swelling and you're going to the bathroom a lot at night, because that's natural, the key would be put your legs above your heart or lift your legs up during the day when you're not sleeping to help get rid of some of that fluid. But that can be a problem because people lay down. That's the first thing they do. And then all that fluid gets moving around and then you're going to have to pee.
What about when you sleep? Like my issue is I'll fall asleep and I think I'm asleep for 3 hours and it's been 15 minutes.
Mm-hmm.
And that goes on all night long.
Yep.
I don't sleep more than 2 hours at a time.
So usually I tell people to don't look at the clock. And go by how you feel. Do you feel like I could get up? Now you can have an alarm to get up. And if you don't hit it, it's not time to get up. But if you wake up and like, wow, I could keep sleeping. But if you wake up and be like, I am 100% awake, I'm not tired, whatever, then you could get up, but don't start your day. Like don't do your cleaning or do your routine until the alarm goes off. But sometimes it's just if you kind of woke up and you think, and if you're still tired, just allow yourself to keep sleeping. But try and avoid looking at the clock can help.
I thought this talk was gonna put me to sleep.
Well, happy
That's
to.
the opposite effect. I have a bed that, it's kind of like a hospital
Yes.
bed, raises your leg,
Yep.
and they call it zero gravity.
Yep.
I find that is the only way that I can sleep. When I go to a hotel room or traveling, it's terrible.
Yeah.
It's the pillows and stuff underneath.
Yeah.
So what is there any recommendation on those adjustable beds?
So the question is adjustable beds. So we don't really have any clear evidence what is the best for you, like zero gravity, that kind of stuff. A lot of it's what you feel comfortable with. except if you have sleep apnea or if you have a lot of reflux, having the head of bed elevated will help the sleep apnea and help reflux. So I'll frequently tell people, like, if they're having a hard time or just mild sleep apnea or a lot of reflexes, having that head of bed elevated can help with that. And so that can help. But what you do with your leg, it's really just finding what's comfortable for you. But it is true, if you get used to it, and then you go to a hotel, they're not going to have something like that. So then you're out of luck. You're going to have a hard night's sleep.
Or slide it underneath where your legs go.
Yeah. You know,
Pillows, that,
yep.
you know, so I kind of try.
And then for those people that don't have those fancy beds, they do make wedges for people with sleep apnea GERD that you can put
Yeah.
under there, the wedges. And I even tell people sometimes just take a couple 2x4s and put under the head, and that just lifts everything up. Because what you don't want just the head to go up, so then you're like this, you know, that doesn't help. You got to have the core be kind of up too, like your chest be up, not just the head. So pillows don't work because then you just end up like this laying down. You got to have your chest up.
Well, I wanna be thoughtful about, we have class coming
Yes.
in at 5:30, so I'm gonna go ahead and cut off the Zoom and let Dr. Bodkin, say that 10 times fast.
Yep.
Sign off, and
Yep.
thank you, everyone.